Good afternoon. I'm AFTD Program Manager Matt Sharp. This afternoon, we will feature a diverse group of sessions, beginning now with a look into one of the most difficult to deal with symptoms of FTD, apathy. During Dr. Massimo's presentation, you will be able to type questions into the questions and answers. Dr. Massimo will answer as many questions as possible after her presentation. Now to introduce our presenter. Lauren Massimo is an assistant professor at the University of Pennsylvania in the School of Nursing and in the Penn Frontotemporal Degeneration Center. Dr. Massimo's expertise is in understanding the neural basis for apathy, for which she has received NIH funding to study. Dr. Massimo also received a 2018 AFTD Wellbeing and FTD pilot grant to further her research into apathy and potential ways to mitigate its presentation in FTD. Dr. Massimo, thank you so much for joining us.
Thanks so much, Matt. And thank you to the AFTD for inviting me to be here to talk with you about apathy. So here are the outline for this session. First, we're going to talk about what apathy is, what it looks like, and I'm going to ask you to share your own definition of apathy. Next, I'm going to talk about the science of how we understand the behavior of apathy that occurs as a result of dysfunction in the brain. And lastly, we're going to talk about how we can use our understanding of brain behavior relationships to promote tailored interventions for apathy. So I first want to open up this session by just sharing some common themes that I hear from caregivers who are having to manage their loved ones with apathy. He used to be busy all the time, and now he just sits there. Nothing gets done unless I make it happen. And I'm tired of nagging. Should I just let her be? And from persons with FTD, we hear things like this. My doctor said I should be active, but I don't know how to start. And I just don't feel like doing anything. So do these statements sound familiar to you? So what is apathy? So I'm going to ask my tech friends to push out a poll, and I want you in the audience to type in the one word that comes to mind when you hear apathy. And we'll wait for a minute or so for the results to come in. And I'll be interested to see if your definitions match mine. So I think this is great. We're seeing a lot of, I see disinterest, uncaring, uninterested, lack of initiative, emotionless. So again, we have these kind of heterogeneous descriptions of apathy. And you guys are right. Apathy has been described in many ways, such as passivity, loss of interest, lack of spontaneity, lack of motivation. And more recently, though, researchers have adopted the definition of apathy as a reduction in goal-directed behavior. But what does this mean? It's behavior that has a purpose or a goal, right? Like washing the dishes or even getting dressed is a type of goal-directed behavior. So why should we care? Why should we not be apathetic about apathy? Well, apathy is one of the most common behaviors, if not the most common behavior in FTD. It is present in over 80% of individuals with behavioral variant frontotemporal degeneration and early on in their disease, and is often described as the first symptom that people notice. It's highly prevalent across all of the FTD syndromes, including individuals with primary progressive aphasia, progressive supranuclear palsy, and corticobasal syndrome. And importantly, apathy is associated with a number of poor patient outcomes, including worsening cognitive impairment, accelerated rate of functional decline, right? Because these individuals are just not engaged. And so they lose more and more of their ability when they just sit around. This disability then leads to early nursing home placement, and even mortality has been reported to be greater in persons with apathy. So all of this evidence suggests that we really need to pay close attention to this symptom. And apathy is a great source of caregiver burden. In fact, apathy is frequently rated as the most burdensome and stressful behavior for caregivers to manage. It's very difficult to try to motivate someone when they are just content sitting around. So I want to point out the important distinction between apathy and depression. Apathy is often confused with depression, and many of you have probably experienced this. People with FTD are misdiagnosed with depression for years before the diagnosis of FTD is made. But there's a body of research that tells us that these are in fact two different symptoms. They have some shared features that you see here in the middle column, things like fatigue and low social engagement and sleepiness. But in apathy, there's distinct features like blunted emotional response, slowing down of thoughts or movements, and lack of concern. So it turns out that when we study the brain regions associated with apathy, there are distinct differences than what we see in people who are depressed, which again further supports the notion that apathy and depression are indeed distinct entities. In this 2009 study, we asked caregivers if apathy was present in their loved one. And we see here that apathy was associated with a very broad range of atrophy in the gray matter, a loss of gray matter in the frontal lobe. So you see here that apathy just covers this huge part of the frontal lobe. But what we know is that the frontal lobe is organized around certain functions. And so we wondered if there were different mechanisms in the frontal lobe that were driving apathy. And so when we look more closely with an experiment that was designed to study different symptoms that we see in apathy, we saw that there were these partially distinct areas of the frontal lobe that were affected and then correlated with different symptoms of apathy. So let me tell you a little bit more about these distinct impairments that we see in persons with apathy. First, we see reduced initiation, and this is a word that came up in the word cloud. And this reduced initiation was related to a structure called the anterior cingulate, which is pictured here in red. The cingulate's a part of the brain that is important for initiating action. And so we believe that persons who are unable to initiate action become apathetic. These are the folks that we see who sit quietly in a room for hours without speaking. The second mechanism underlying apathy is an impaired ability to plan. And this was related to a structure in the dorsolateral prefrontal cortex here in green. This region is known to be important for executive function, which is a cognitive domain that is frequently impaired in individuals with FTD. We live in a busy world, right? And we're expected to do many things at once. And we think that persons with FTD can develop apathy when they're unable to plan and organize and structure their activities. And lastly, we see that poor motivation was associated with the orbital frontal cortex. This area is known to play a role in determining information regarding the interpretation of reward. And so we believe that apathy can occur when persons with FTD lack the ability to be motivated by positive reward signals like praise for a job well done, or by the inability to interpret negative signals like scowling at your loved one for not taking out the trash. So then the question I think becomes, are these symptoms and these different apathy symptoms sensitive to different interventions? And so now with a more refined knowledge of why apathy occurs, we can think about how we can target each underlying mechanism. And here are just a few examples. Initiation may be improved with something called external sensory cueing. And there's some evidence for this in Parkinson's disease where these patients have a lot of difficulty with initiation. External sensory cues are externally initiated prompts like auditory prompting or visual stimulation to get the person going on an activity. And in the same regard, multisensory stimulation can enhance the sensory signal and can be useful to activate a person with apathy. So multisensory stimulation is sometimes used in nursing home settings in a room where the sensory stimulation can be controlled. And so they have persons with apathy do things like blow bubbles, touch Play-Doh, use finger paint to encourage engagement at the same time that they're playing music. So again, they're stimulating multiple senses. But for people who have planning difficulty and who are already disorganized, this additional noise can really be very overwhelming for them and may even worsen their apathy. So for people with planning impairment who have difficulty with mentally manipulating a task or an activity, it's important to think about cognitive limitations and to prescribe activities based on the person's strengths. And speech and language therapists, occupational therapists, and recreational therapists are really great resources for this. Individuals who are disorganized may need to be in a more structured environment where their choices are constrained and their activities are laid out in a straightforward, step-by-step manner with frequent cueing. And for individuals where I want to target motivation, it's important to think about what types of activities are rewarding and using rewards to engage persons with apathy. For example, we know that in people with FTD, food is often a good motivator. So think about what incentives you can use to motivate your loved one. And lastly, interventions like music therapy, especially music that's live and interactive, and physical therapy have been shown to improve apathy and may help across these different domains. So I want to mention our app AFTD. With generous funding support from the Association for Frontotemporal Degeneration, we developed and tested an app called AFTD, which takes the strategies that I just outlined and incorporates these in a mobile health application. And the goal is to really help people with apathy to engage in activities. And while I don't have time to go into the app in too much detail, some of the features that we found were useful in our participants included push notifications to help people with apathy initiate their activity. We scheduled activities for the person with apathy in the app and then provided simplified step-by-step directions for how to complete the activity. And finally, we used fun sounds and music and progress bars to motivate individuals with apathy to complete their activities. So I just want to touch on medications, and unfortunately, there's no magic bullet here. There's been a few small studies examining the efficacy of medications to treat apathy, and the evidence just isn't there for any one treatment in particular. So the first line is to really use those non-pharmacological strategies that I just outlined. The evidence for the use of antidepressants to treat apathy is pretty limited. In some people, it may be helpful, and in other folks, it may actually worsen their apathy. Stimulants may be helpful in certain cases, like those people who have difficulty with initiation. It may just be helpful for getting those folks going, getting them started. But we need to use these medications with caution because there are side effects that are associated with this class of medications. And there are certainly other agents that are under investigation, like oxytocin, for example. So to conclude, apathy is one of the most common and disabling symptoms that occur across the FTD disorders, and we need to pay close attention to apathy. When we understand what's happening in the brain, we can use this information then to inform our treatments. And I talked about some of the work that we're doing in apathy, but I hope that we can take a look at other behavioral symptoms in FTD in the same way, really understanding what the neural drivers are of the behavior with the goal of individualizing our therapy. And so I want to take a moment to acknowledge the generous funding support that I've received from the AFTD and the NIH to study apathy. I also want to acknowledge the incredible group of people that I work with in the University of Pennsylvania Frontotemporal Degeneration Center who are dedicated to studying FTD disorders. And lastly, I want to also plug our upcoming Penn FTD Center Conference for Caregivers, which will be held on Friday, June 18th. This is going to be a virtual conference, and the link for our registration is here and will be shared widely next week. So thank you. And with that, I will turn it back to Matt for questions, I think.
Thank you, Dr. Massimo. I think we do have a time for a couple questions. The first one is people are interested in how can they access the app? Is there any way they can download it? We are not there yet. We're very close, actually. So we are just finishing up analyzing our data from our study that, again, was funded by the AFTD. And the data look very good. We were able to engage people with FTD to use the app, and they were able to
achieve their goals with the app. We were able to see a little bit of reduction in caregiver burden as well. So we were quite pleased with the results. This was tested on one platform, and now we are working with the folks in technology here at the University of Pennsylvania to be able to expand this to other platforms so that it would be easy to be downloaded from, like, the App Store. So stay tuned for that.
Excellent. Well, yeah, we definitely will be, and make sure everybody knows more about that as we get more information. We had a question about melatonin, and one 2016 study found that the melatonin agonist antidepressant Melatonin improved apathetic behavior in behavioral variant FTD patients. And melatonin itself has shown some promise in MCI and Alzheimer's. Do you have any thoughts or comments about melatonin and Melatonin?
Yeah, so I think I know that the study this person is referring to, I think that for the preliminary results from the study, look okay. What we need, though, more widely are larger powered studies that are, randomized controlled trials, which is essentially the gold standard for when we can actually say whether a medication is efficacious or not. And so I can't speak specifically about any medication in particular, because I think that it's always just really important to have that information, to have the information in hand, but then to also talk with your provider about whether the provider believes it would be useful to use for a person's apathy.
Thank you. Thank you. We have another question. Says, my loved one was diagnosed at age 82. Does apathy look different in people, older individuals, than it does perhaps in more typical 50, 60-year-old person with FTD?
That's a great question. I think that, again, I think that we need more studies of apathy, certainly. And we need more studies of the different domains that I described that contribute to apathy as well. Regarding, age, certainly we see that apathy occurs in along with age. So even people that are cognitively normal, there can be apathy in the general population. So apathy certainly is related to the aging process. I think that it could perhaps look a little bit different because it could be also related just to the level of activity that 80-year-old person was doing, prior to their disease. So I think it just kind of just depends on an individual level what their current level of activity was prior to their condition.
So, okay, yeah. So the change basically is helpful. Well, thank you. There's a question about ADHD meds. Some of the symptoms of apathy sound similar to ADHD. Would ADHD medications like Vyvanse be useful?
Yeah, so some of the medications that are used for ADHD, even stimulants, for example, in some small studies of apathy have been found to be useful for treating apathy. However, in some cases, the stimulants can also make people with apathy worse, right? So if you think about these different domains of apathy, so for example, the people who have problems with their organization, the problems with planning, if you give someone a stimulant who is already disorganized, it could make their difficulties even worse and then worsen their apathy. And so I think that, again, I'm going to go back to the fact that we just need more well-powered studies where we can look at also these domain-specific entities of apathy to say whether certain medications perhaps are more helpful in different domains of apathy.
Thank you. And speaking of those different domains, are there specific or special scans people need to find in order to detect the changes in those domains?
I'm not sure I understand the question. Do you mean like an MRI scan?
Yeah, is an MRI useful in that for that purpose?
Yeah, I mean, so we certainly use it in research, right, to better understand the brain behavior relationships, but to try to understand what, again, the neural drivers are of apathy. But you know, in clinical care, that's not typically done.
Okay, gotcha. So mainly through research.
Exactly, mainly through research and to really further our understanding of why apathy occurs, and again, what the drivers are of apathy. But it's, again, generally not done in clinical care.
Gotcha. So along the lines of clinical care, it's hard to break down the effects of apathy, initiation planning, and motivation. They all seem to lump together. Do you have any suggestions or recommendations about how do you identify different ones and how do you approach them once you figured out how to tell them apart?
Yeah. So another great question. I mean, certainly we do this in research. There are a few different scales that can be used to break down apathy. So we try to get at the different questions, right? Like, does your loved one have difficulty with motivation? Does your loved one have problems just getting going? Does your loved one seem to be overwhelmed when an activity is too complex? So those are the types of questions that we can ask to really get at these different domains of apathy.
Are those scales available to, to people at home, spouses and family caregivers? And where would they find them?
So the scales, are they available to caregivers at home? Probably not. I mean, they've been published in papers, and certainly caregivers can have access to publications. I'd be happy to share the publications. One is the multidimensional apathy scale. And so that is a scale, again, that is used and has been examined in individuals with FTD to, again, get at this domain-specific apathy. So that it would be a scale available. There's been a couple of different publications on that scale as well.
That would be great, because actually the next question was about how do people find publications. That would be helpful. So if you have any that can be shared, that would be wonderful.
Absolutely.
Thank you. Thank you. That's great. So I think we have time for a few more questions. Can you comment on apathy versus anhedonia in FTD, and perhaps start with a definition of anhedonia?
So anhedonia, are the loss of pleasure. There's actually just a nice paper that was just recently published on this very topic. Speaking of publications, which again, you can see anhedonia in apathy, right? They have this kind of loss of interest, and they just don't seem to enjoy the things that they once did. But again, going back to the research, and this paper nicely points out that these, again, are two distinct symptoms, and that there are distinct neural drivers of both of these symptoms. So
does that mean in some ways that people with apathy can still experience pleasure from activities on some level? It may just be harder to see what that looks like.
Exactly. That's exactly right, Matt.
Excellent. Excellent.
And that goes back to the motivation component, right? And some people have difficulty with motivation. They're not motivated by the things that they once used to be motivated by, or the activities that they used to participate in may just be too overwhelming for them to think their way through, right? But they can still, if they have a little support, they could still find pleasure in those activities.
And they just, need that little push sometimes to get started.
Right. Mm-hmm.
Excellent. Excellent. While we're on big words, how would you correlate anexnosia with apathy? So is there any connection between inability to recognize your own symptoms and apathy?
Yeah. So, these are two very common symptoms in people with FTD, right? A lack of self-awareness and apathy as well. The relationship between the two, again, has been studied neuroanatomically. And again, the loss of insight and apathy, in some cases, they share some neural basis. So the orbital frontal cortex is important for self-awareness. The cingulate's important for self-awareness. So again, we have these same neural drivers that can produce these symptoms, such as lack of self-awareness and apathy.
Excellent, thank you. So I think we have time for maybe one more question, and sort of more broadly, is there any training available for like staff in assisted livings or nursing homes on how to manage apathy?
That's also a great question. I would point people to the Partners in Care brochure, the Partners in Care document that is on the AFTD website, and I think was also linked as part of the conference. There are a couple of, again, good recommendations in that paper for different strategies to help engage people with apathy. I would say, a great resource that nursing homes often have are things like, recreational therapists, speech and language therapists, occupational therapists, who again can really help with prescribing the right types of activities for people that are based on their limitations, that are also based on what motivates them, that are based on their personal preferences. So again, I think that engaging the help of those therapists in the nursing home setting would be essential to helping people with apathy.
Thank you. Yeah, and for anybody who's interested, as Lauren was saying, that issue of Partners in Care is available on the resources section of the conference page, but it's also available on our website as well. So if you do have any follow-up questions regarding where to find it, please just reach out to our helpline. And with that, I would just say thank you so much, Dr. Massimo, for such a great presentation. This has really been fascinating and definitely gives me a different sense of what apathy really means and what it really is. So thank you so much for your time today.
Thanks for having me, Matt.